Hello, a very good evening to everyone. I welcome you all in this live session. This is Dr. Poonam here, your anatomy educator on Medicoz Community platform. Before we starting, please let me know if the audio and visuals are proper. Okay, so before starting the session, I would like you to introduce to Medicoz Community platform. So this is an e-learning platform which is designed for the students who are preparing for National Exit Test 2024. You can log on to their website, that is www.medicozcommunity.com, where you will get various resources provided by this platform. Here you will get live interacting sessions which is provided by the subject experts to make the understanding better. You will get various question bank and the test series for the preparation of your exam. So here is an early bird offer where 3,000 applicants will get various offers on different plans. I hope you all will take this opportunity and register yourself. Okay. Now I'll start with the today's session, that is 25 most important clinical based anatomy questions. This session has two parts, part 1 and part 2. Part 1, that is today, where I'll be discussing 12 MCQs of anatomy, and part 2 will be tomorrow, that is on 3rd March at 7 p.m. Where I'll discuss remaining 13 questions. So now I'll start with the session. Okay. Let me check if there is any issue with the audio and visuals. Okay, so the question number 1 for this series is, an examination of a patient with carpal tunnel syndrome may reveal all the following symptoms and signs except which. So here we have to find out the sign and symptom which is not related to the carpal tunnel syndrome. And the options are option A, that is atrophy of a muscle which is in the thenar eminence. Okay. Now the option B is weakness in the opposition of the thumb. Option C is loss of skin sensation on the anterior part of the palm. Option D, loss of skin sensation on the anterior surface of the index finger. And option E, that is normal skin sensation on the anterior surface of little finger. So to find out the answer, we just have to understand that the carpal tunnel syndrome. Now the carpal tunnel syndrome, there is a flexor retinaculum and this tunnel is formed below it. Okay, and the nerve which is passing through it, and there may be a chances of compression of that nerve, and the nerve is the median nerve. Okay, now the median nerve, as it passes through this retinaculum, so what happens, due to inflammation of the tendons which are also passing through this tunnel, okay, so they can compress your median nerve. Now we all know the nerve supply of the median nerve in the hand. So here this is the diagram which is showing the nerve supply of dorsum and palmar aspect of the hand, and here we have three nerves: ulnar nerve, radial nerve and median nerve. So here we can see in the palmar aspect of the hand, the lateral half of the palmar aspect of the hand, including the lateral 3.5 digits, they are supplied by the median nerve, and the medial part of the palm and the medial 1.5 digit, that is supplied by the ulnar nerve. Now what was the scenario there? The carpal tunnel syndrome. So in the carpal tunnel syndrome, if the median nerve is getting compressed here, so obviously it will affect this area, including the lateral 3 digits and this area of our palm, which you can say lateral half of your palm. Okay, now in the lateral half of the palm, on the base of the thumb, there is a group of muscle, and that group of muscle is called as the thenar group of muscle. Now this thenar group of muscle, that is providing the eminence here, which is called as the thenar eminence. Okay, now we will look into the options again. So what was the first option? That is option A, atrophy of the muscles of thenar eminence. So obviously there will be the atrophy of the muscles of thenar eminence because the median nerve is getting compressed here. Okay, and this thenar eminence is provided by the thenar group muscles, and these thenar group muscles are supplied by the median nerve. Okay, now this is the correct point here, which is related to the carpal tunnel. You can see the sign and symptom in the carpal tunnel syndrome. Then we have next option, that is option B, which is weakness in the opposition of thumb. Now again, the movement at the thumb, that is provided by the muscles of thenar group, and there is a muscle with the name of opponens pollicis, which is causing this action at the thumb, which is opposition. Okay, so if the median nerve is getting compressed here, so again it will involve this muscle here, and which will affect the action of the opposition of thumb. So again, this is the point which is related to the carpal tunnel. Then we have the C option, that is loss of skin sensation on the medial part of the palm. Now this can be our answer. You can see here in this diagram. The medial aspect of the palm is supplied by the ulnar nerve. Okay, and here we are talking about the median nerve. So this is our answer, that is option C. So in carpal tunnel syndrome, out of all these options, this option C, that is loss of skin sensation on the medial part of the palm. You will not get the sign there whenever there is this carpal tunnel syndrome. Now we can see to this option D and E. So the option D is loss of skin sensation on the anterior surface of index finger. That will be there because the lateral 3.5 digit, that is your thumb, your index finger, and the lateral half of your middle finger, that is supplied by our median nerve. So there will be the loss of sensation on the anterior surface of the index finger in the carpal tunnel syndrome. And this is our option E again, which is the part of the carpal tunnel. How? There will be the normal skin sensation on the anterior surface of little finger. Why? Because this area is supplied by the ulnar nerve here, and ulnar nerve is intact because we are talking about the carpal tunnel syndrome, and it is related to the injury to median nerve. So that's how we have got our answer, that is the option C. The option C is loss of skin sensation on the medial part of the palm. It is not the sign and symptom of the carpal tunnel syndrome because this area is supplied by the ulnar nerve. Now we will proceed for the question number 2. Yes, if you guys have any doubt, you can drop your message in a chat box. Okay, so we can start with the question number 2. So again, in the question number 2, we have a condition here which is regarding a winged scapula, which is also known as the winging of scapula. The following facts are correct except which. So here we have to find out the fact, the point which is not related to the winging of scapula. So the options are option A, the spinal part of accessory nerve is damaged. Option B, the inferior angle of the scapula projects backward. Option C, the serratus anterior muscle may be wasted. Option D, the long thoracic nerve is damaged. And option E, the scapula can no longer be pulled anteriorly around the chest wall. So here we have 5 options. So if you guys has any idea, you can drop your message in a chat box. Which option can be correct here? Option C. For this question number 2, option C is not the correct answer. Okay, I'll tell you. Here you can see this is the image which is showing the winging of scapula. So this is a condition which is called as winging of scapula. First we will understand what is this winging of scapula and what is the cause of it. Okay, so the winging of scapula, here you can see the prominency of the medial border and inferior angle of the scapula is here. And how this prominency will occur here, you will ask the patient to push against the wall. Okay, so when you will ask the patient to perform this activity, what will happen if there is this winging of a scapula present in the patient, the medial border and inferior angle of the scapula will be prominent. Okay, and it happens why? Because there is the paralysis of serratus anterior muscle. So we have a serratus anterior muscle here which is attached to the medial border and inferior angle of scapula, and it is taking origin from the ribs. Okay, now what happened when there is paralysis of this muscle? So this muscle is also known as the boxer's muscle. Clear? Now this when the serratus anterior is paralyzed here, so you will ask the patient to find out the condition. You will ask the patient to push against the wall. Okay, and when there is paralysis, this symptom will appear here. You will see this appearance there. And why this serratus anterior is paralyzed here? Because this serratus anterior muscle, it is supplied by a nerve, and the name of this nerve is long thoracic nerve. And this long thoracic nerve, it is again a very important nerve, and it is arising from the upper trunk of brachial plexus. This nerve is also known as the nerve to serratus anterior and nerve of Bell. Nerve of Bell. Okay, so you just have to remember this point here. So this whenever there is injury to this long thoracic nerve or upper trunk of brachial plexus, what will happen? There will be the paralysis of serratus anterior muscle, and you will see this feature there, that is called as the winging of scapula. Now we have got all the points that is related to the winging of scapula. What are these points? The paralysis of serratus anterior is there. Okay, the injury to long thoracic nerve is there because it is supplied by the long thoracic nerve, and that's how your serratus anterior will get paralyzed. And this winging of scapula, where there is the prominence of medial border and inferior angle of scapula. So these are the points that is related to the winging of scapula. Now we will look into the options. Yes. So there is option A, that is spinal part of accessory nerve is damaged. So this part we have discussed here, and I haven't mentioned about the spinal accessory nerve here. Yes. So do you know what is this spinal accessory nerve, and it is supplying which muscle of your body? Any answers for this? Okay. The spinal accessory nerve, if it is damaged, it will cause the paralysis of a muscle, that is sternocleidomastoid and trapezius. Okay, so you know the answer here. Here we are talking about the serratus anterior and long thoracic nerve. Yes. Now the answer for this question is, we have got the answer in very first, that is the spinal part of accessory nerve is damaged. Because in winging of scapula, the nerve which is damaged here, that is the long thoracic nerve, and the muscle which is paralyzed here, that is the serratus anterior. So the spinal part of accessory nerve is the answer of this question. Okay. Now we will look for another options as well. You can look into the option B. What is that? The inferior angle of scapula, it project backwardly. Here you can see this. The inferior angle of scapula, it is projecting backwardly and it is prominent here. So this is the point which is related to the serratus anterior paralysis or winging of scapula. Then the option C. The serratus anterior muscle may be wasted here. Yes, the serratus anterior muscle will be wasted because this muscle is paralyzed here, and there may be a wasting of this muscle. So this is the question, this is the point which is related to the winging of scapula. Now we have option D, that is long thoracic nerve is damaged. Obviously the long thoracic nerve is supplying the serratus anterior and it is paralyzed here. And why it is paralyzed? Because the long thoracic nerve is damaged. Okay. Okay, now this option is the scapula can no longer be pulled anteriorly around the chest wall. Yes, you cannot do this movement here because the action of the serratus anterior muscle, it pulls your scapula around your chest wall and forwardly, so you will no longer be able do this movement. You cannot be able to do this movement when there is the paralysis of serratus anterior muscle. Okay, so I hope you got my point here, and the correct option is option A in the winging of scapula. Any questions? Yes, Suman Kumari, option A. Very good. This is the correct answer for this question. Yes. Now we have question number 3. So the question number 3 is, after injury to the nerve at the wrist. So we have a condition here. There is an injury at the wrist. Okay. And there is a nerve which is getting injured here. And when that nerve is injured here, what is the condition? The thumb, it is laterally rotated and adducted, and the hand, it looks like flattened and ape-like. Okay, now we have to find out the nerve which is damaged here. Okay, so the options are option A, anterior interosseous nerve, option B, ulnar nerve, option C, deep branch of radial nerve, option D, median nerve, and option E, superficial branch of radial nerve. So we have to find out the answer here. So anybody, if you know the answer, you can drop a message in a chat box. No, option B is not for this question. It is not the answer of this question. Okay, I'll tell you the answer of this question. Okay, you can see we have anterior interosseous nerve, we have ulnar nerve here. Okay, anterior interosseous, ulnar nerve, deep branch of radial nerve, superficial branch of radial nerve, and median nerve. So basically we have 3 nerves here: ulnar nerve, median nerve, and radial nerve. Okay, now you can see this is the option A, which is the anterior interosseous nerve. So anterior interosseous nerve, it is a branch from median nerve, and it is only supplying the muscles of your forearm. Now what is the condition here? Here you can see the thumb is laterally rotated and adducted. So it means there is the involvement of the muscles of hand. So your anterior interosseous nerve, it is out from the option. Okay, now we have option B, that is the ulnar nerve. Ulnar nerve, again, it cannot be the answer for this question because there is the involvement of thumb, and the ulnar nerve, it is supplying your little finger and your medial half of ring finger, and it is supplying the muscles of your hypothenar eminence. So ulnar nerve cannot be the answer for this. Then we have deep branch and superficial branch of radial nerve. Now remember one thing, in case of upper limb, yes, we have 3 parts of the upper limb: arm, forearm, and hand. Yes. Now the arm has anterior and posterior compartment, forearm has the same compartment, anterior and posterior, and hand, it has palmar aspect and dorsum of the hand. Yes. Now what happens, just remember this thing. The arm, the anterior aspect of the arm, the muscles, they are present there, no, they are supplied by the musculocutaneous nerve. Okay, now the muscles of the forearm in the anterior compartment, they are supplied by the median and ulnar nerve. Now the muscles of the palmar aspect of the hand, that is the thenar and hypothenar muscles, they are supplied by the median nerve and ulnar nerve. Median nerve is supplying the muscles of thenar group, and ulnar nerve is supplying the muscles of hypothenar group. Now we are left with the radial nerve. Now remember this thing, radial nerve, it is not supplying the anterior aspect of any part of your upper limb. It is only supplying the entire posterior compartment of upper limb. That's why the radial nerve is called as the nerve of posterior compartment. Clear? So again, here we have the thumb that is laterally rotated and adducted. Okay, so this is again due to the impairment in the action of thenar muscles. So we can take this out. The radial nerve and superficial and deep branch of radial nerve, these are not our option. Now we are left with which nerve? We are left with the median nerve. So median nerve is the answer of this question. Let me see how many of you have given the right answer. Yes, Tushar Rao. Yes, very good, Tushar. The answer is D, that is the median nerve. Okay. Now, what is the condition here? The thumb is why the thumb is laterally rotated? Due to the paralysis of the muscles of the thenar group. Yes. And why the thumb is adducted? What is the reason for the adduction of the thumb? Here you can see in this diagram, this is the image which is showing the ape-like thumb or ape hand deformity. Okay, here you can see the flattening of the thenar eminence, and thumb is laterally rotated and adducted. Laterally rotated, why? Because there is the paralysis of the muscles of thenar group. Why this thenar eminence is flattened here? Again, due to the paralysis of the muscles of thenar eminence, because these muscles are supplied by the median nerve here. And why the thumb is adducted? The thumb is adducted here because there is a muscle. The name of this muscle is adductor pollicis. As the name suggests, adductor means it will cause adduction, pollicis means thumb, so it will cause adduction at the thumb. But why this muscle is acting here? Hence it is a muscle of your thenar group. No, this is a muscle of thenar group. Then why this muscle is working here? Why there is the action of this muscle is intact here? What is the answer for this? Because the adductor pollicis, it is a muscle here which is also supplied by the ulnar nerve. Okay, and in our case only the median nerve is getting injured here. So in that case the adductor pollicis will be intact due to unopposed action of the ulnar nerve. There will be the adduction of the thumb. Okay, that's why we have the adduction of thumb. Your thumb will undergo the adduction and laterally rotated whenever there is the injury to the median nerve and paralysis of the muscles of thenar group. Okay, so this is the answer for this question, that is the median nerve. I hope I'm clear to everyone. If you guys have any doubt related to these points, you can ask me in the chat box. Now we will start with the question number 4. So what is the question number 4? A femoral hernia has the following characteristics except which? So we have to find out the characteristics of the femoral hernia, but there is a point. We need to find out the point which is not related to the femoral hernia. So the options are option A, that is, it is more common in women than in men. Option B, the swelling occurs below and lateral to the pubic tubercle. Option C, it descends through the femoral canal. And option D, its neck is related immediately lateral to the femoral artery. Okay, so these are our options. Anyone, if you know the answer, you can send your answer in the chat box. So to find out the answer of this question number 4, we just have to look into this diagram. Here you can see this is the diagram sorry, which is showing the anterior compartment of the thigh. Okay, here we have this ligament here which is called as the inguinal ligament, and just below the inguinal ligament here we have a triangle which is called as the femoral triangle. Sorry. Okay, so we have the triangle here which is the femoral triangle. Now there are the content of this femoral triangle. Lateral to medially we have femoral nerve, then we have femoral artery, and most medially in this triangle we have a structure that is the femoral vein. Okay, Now this femoral artery and femoral vein, it is covered with a sheath which is called as the femoral sheath. Okay, that is called as the femoral sheath. Now this femoral sheath has an opening here which is called as the femoral ring, and this femoral ring has 3 compartments, and the medial most compartment of this femoral ring is called as the femoral canal. Okay, so this femoral canal, it is only containing a lymph node here which is called as the lymph node of Cloquet. Okay, and this is a very spacey compartment here. So whenever there is increased intra-abdominal pressure, so the sac of the hernia, it can bulge out through this canal. Okay, so we have a femoral hernia, so it can occur through this canal, through the femoral canal. It is lying medial to the femoral artery and femoral vein. Here you can see this is the bulge which is called as the head, and this constricted part here, it is called as the neck of femoral hernia. Clear? So these are the points here which is related to the femoral hernia. Now we will look into the options here. So we have option A, that is the femoral hernia, it is more common in women than men. Yes, it is more common in women because women has a wider pelvis. That's why it is more common in women. And option B, the swelling occur below and lateral to the pubic tubercle. Yes, if there is a femoral hernia, you will find out a bulge part or swelling just below and lateral to the pubic tubercle, because that is the groin area. Then we have option D, that it descends through the femoral canal. Yes, I have already mentioned this point here. The femoral canal, it is the site from where the femoral hernia can occur. Yes, now we have the option D, that is the neck of this femoral hernia, it is related immediately lateral to the femoral artery. Now this is the option which is wrong here, which is not related to the femoral hernia, because here in this diagram you can see the neck of femoral hernia, it is lying medial to the femoral artery and femoral vein. And what is the option here? It is lying lateral to the femoral artery. So this is the point here which is not correct, which is not related to the femoral hernia, and this is the answer for this question number 4, that is the option D. The neck of the femoral hernia, it is lying immediately lateral to the femoral artery. It is not. Where it is lying? It is lying medial to the femoral artery and femoral vein. So it has a medial relation, not the lateral one. Clear? So this is our question number 4. I hope all of you have got my point here. Everything is clear to you all. Okay, now we will proceed for the question number 5. The question number 5, if the foot is permanently dorsiflexed and everted, which nerve might be injured here? So we have a condition here. The patient has a dorsiflexed and everted foot. So we just need to find out which nerve is injured here. So the options are option A, the deep peroneal nerve, option B, the superficial peroneal nerve, option C, the common peroneal nerve, option D, the tibial nerve, and option E, obturator nerve. Okay, so we have these 5 options here. You can message your answer in the chat box for this question number 5. Dhruv Kumar, question option C, no. Okay, I'll tell you what is the answer for this question. For that, we just need to look into the nerve supply of the lower limb. Okay, now here you can see this is the diagram which is showing the nerve supply, and we all know there is a nerve which is called as the sciatic nerve in the posterior compartment of the leg. Okay, now what happened when the sciatic nerve, it come here in the popliteal fossa. At this level, it is dividing into 2 divisions, 2 terminal division. One is called as the tibial nerve, okay, and another is called as the common peroneal nerve. Now later on, this common peroneal nerve is dividing into superficial and deep peroneal nerve. Clear? So tibial nerve, it is supplying the muscles of posterior compartment of leg, and common peroneal nerve, it is supplying the muscles of anterior and lateral compartment of the leg. Clear? So now we have got the nerve supply for the different compartment of the leg muscles. Clear? Now we look into this question here. The scenario is the foot is dorsiflexed and everted. The foot can be in dorsiflexed and everted position when there is the paralysis of the muscle. They are causing plantar flexion. Okay, so due to the unopposed action of the muscles of the anterior compartment of your leg, okay, your foot will go into dorsiflexion and eversion. So now we have got the point here. There must be a paralysis of muscles of posterior compartment of leg. Okay, and at this point we all know the muscles of posterior compartment of leg, that is supplied by the which nerve? Tibial nerve. Okay, so the answer for this question is the tibial nerve. So when the tibial nerve is injured here, it will cause the paralysis of the muscles of posterior compartment of the leg, because the muscles of posterior compartment of the leg are the plantar flexor of the foot. Okay. So when this muscle will paralyzed here due to the unopposed action of dorsiflexors, your foot will undergo the dorsiflexion and eversion. So the right answer is tibial nerve, because it is supplying the muscles, they are causing plantar flexion at your foot. Okay, so we have got the answer here, the tibial nerve. Deep peroneal nerve and the superficial peroneal nerve cannot be the answer, because the superficial peroneal nerve, it is a cutaneous nerve. Deep peroneal nerve, it is supplying the muscles of anterior and lateral compartment. Common peroneal nerve, again it is dividing into deep and superficial, which is related to the anterior and lateral compartment of your leg. Obturator nerve cannot be the answer. Why? Because the obturator nerve, it is supplying the muscles of medial compartment of the thigh. Okay, so it is out from our option, all these three, and then we have answer here, which is the tibial nerve. So when there is injury to the when there is the paralysis of the muscles of posterior compartment of the leg, the foot will undergo the dorsiflexion and eversion, and it occurred due to the injury to the tibial nerve. Okay. Yes. If you guys have any doubt, you can ask me related to this question. Okay. Now we will proceed for the question number 3. Injury to the common peroneal nerve. Again, this is the similar question to the previous one. Injury to the common peroneal nerve result in which condition? We all know the common peroneal nerve, it is supplying the anterior and lateral compartment of the leg, and we have the options here: inability to invert the foot, inability to plantar flex the ankle, inability to feel skin sensation on the medial side of the leg, and inability to invert the foot. Okay, what can be the answer here? Inability to invert the foot. The foot inversion is caused by the muscles of posterior compartment of the leg, which is supplied by the tibial nerve. So it cannot be the answer here. Inability to plantar flex the ankle, again it is done by the muscles of posterior compartment, so it cannot be the answer here. Inability to feel the skin sensation on the medial side of the leg. So the medial side of the leg, the skin over there, that is supplied by the saphenous nerve, and the saphenous nerve, it is a branch of femoral nerve. Okay, so it cannot be the answer. Now we have the answer, that is the inability to invert the foot. Why? The eversion is caused by the muscles of anterior and lateral compartment, and that is supplied by the common peroneal nerve, branch of the common peroneal, that is deep peroneal nerve. Okay, so our answer is inability to invert the foot, which is caused by injury to the common peroneal nerve. I'm sorry. Now we have question number 7. The following statements regarding the Horner syndrome are correct except which? So we have a condition here which is Horner syndrome, and the options are ptosis, give me a second, ptosis, option A, that is ptosis, which may be present because of loss of innervation to the smooth muscle portion of the levator palpebrae superioris. Option B, that is the excessive sweating may occur on one side of the face. Option C, it can be caused by injury to superior cervical sympathetic ganglion. And option D, pupillary constriction may occur because of loss of innervation to the dilator pupillae muscle. Okay, so these are our 4 options. Now we will discuss what is this Horner syndrome. So this is the image which is showing the sympathetic nerve supply to the face, okay, which is if there is any kind of injury to this, any kind of hamper to this sympathetic nerve supply to the face, okay, and the sympathetic nerve supply, it passes through the superior cervical ganglion, and then it is giving a branch to nerve to sweat gland of our face, and dilator muscles of the pupil and the tarsal muscles. Okay, so when the sympathetic nerve supply is damaged here, what will happen? All these 3 nerve supply will be hampered. So when the tarsal muscle, pupillary muscle, and the nerve to sweat gland, that will be damaged here. So we can get all these options here. So you can see the ptosis will be there. In Horner syndrome, the ptosis will be there because of the smooth muscle portion which is supplying your levator palpebrae superioris. So ptosis will be there, which is called as the drooping of the eyelid. Okay. Then we have option B, excessive sweating may occur on the side of face. It cannot be happen because the nerve which is arising from this sympathetic innervation, it is supplying the sweat glands. Okay, so when there is no nerve supply to the sweat gland, so there will be no sweat, which is called as the anhidrosis. Okay, so in case of Horner syndrome, we have ptosis, which is correct. We have anhidrosis, which is called as the loss of sweating. So here in this option you can see it is written here excessive sweating. So excessive sweating cannot be there because there is a condition which is anhidrosis, which is due to the lack of nerve supply to the sweat gland, which is provided by the sympathetic nerve. So this is our answer here, option B. Excessive sweating may occur on the side of face. It cannot be there in case of Horner syndrome. Okay, so we have option B, which is the answer. We will look for the option C and D as well. The option C is it can be caused by injury to the superior cervical. Yes, it can be occur here due to injury to superior cervical sympathetic ganglion, because it passes through it. It arises from here. Then we have pupillary constriction. Yes, pupillary constriction will be there because there is loss of innervation to the dilator pupillae muscle. Okay, so all these signs and symptoms we can find there: ptosis, meiosis, and hydrosis, exophthalmos, but there is no sign and symptom which is showing excessive sweating on the face. So our answer is option B. Now we have another question, that is question number 8. So again we have a scenario here. In question number 8, the compression of facial nerve in the facial canal in posterior wall of middle ear, okay, it could result in all following except which. So again we have to find out the sign and symptom and the condition which is not related to this scenario, the compression of the facial nerve in the facial canal where in the posterior wall of middle ear. So what are our option? The option A, there will be the cessation of lacrimal secretion. There will be the paralysis of posterior belly of digastric muscle, which is option B. Option C is inability to whistle, and option D, decreased saliva in the mouth, and option E, loss of taste sensation to the interior 2/3 of the tongue. Okay, so these are the options here. Now we have to find out which option is not related to the compression of facial nerve in the facial canal in the posterior wall of middle ear. For that, we just have to look into the course of the facial nerve. So here you can see the diagram which is showing the course of the facial nerve. So here you can see this is the course of the, this much part is the course of the facial nerve in the ear. Okay, so here this is the course of the facial nerve in the posterior and the medial wall of the middle ear. And here you can see the explanation for this question. The lacrimal secretion for the lacrimal gland, it is controlled by the lacrimal nucleus of the facial nerve, and the fibers, they are going to supply the facial nerve as the fibers, they are going to supply the lacrimal gland via the facial nerve in a form of greater petrosal nerve, and it is giving a branch on the medial wall of middle ear. Before the facial nerve, it reaches to the posterior wall of middle ear. Okay, now you can see in this diagram here. So here this is the part of the facial nerve in the medial wall, and this is the part of the facial nerve in the posterior wall. So in our case, the the facial nerve is damaged here in the posterior wall. So all these branches arising from the facial nerve, like nerve which is going to your salivary glands, nerve which is going to the tongue, which is going to the parotid gland, and going to the muscles here. Okay, all these branches, they are coming from the facial nerve after this point, from where your nerve is passing through the posterior wall of middle ear. But the facial nerve, it is giving a branch to your lacrimal gland on its medial wall. So this is the point here. The secretion of the lacrimal gland will be intact there, because the branch which is arising from the facial nerve going to supply your lacrimal gland, the name of that nerve is greater petrosal nerve. It is arising from the facial nerve on its medial wall, but we have an injury at its posterior wall. Now we will look into the option here. So our option A, that is there will be no secretion through the lacrimal gland. There will be no lacrimal secretion. No, it cannot be it cannot be there, because there will be the normal secretion from the lacrimal gland, because it is a branch which is arising from the facial nerve on its medial wall, and we have an injury to its posterior wall. So this is the answer here, that is option A. Now we have other options, we will look into it. Option B, paralysis of posterior belly of digastric muscle. Yes, it will be there. Inability to whistle, again it will be there, because muscles of face are supplied by the facial nerve. Decreased salivation in the mouth, yes, it will be there. Loss of taste sensation from the anterior two-thirds of the tongue, all these points will be there except the option A. So our answer is option A. Okay, now we will look into the question number 9. Which of the following nerve might be injured when we are tying the inferior thyroid artery during the operation of thyroid gland? Okay, so we have options here. Option A, sympathetic trunk. Option B, internal laryngeal nerve. Option C, descendens cervicalis. Option D, recurrent laryngeal nerve. And option E, superior laryngeal nerve. Okay, so to understand this, we just have to look into this diagram. Here we have the diagram which is showing the relation of artery and nerve related to your thyroid gland. So here we have, this is the upper pole and this is the lower pole of the thyroid gland. Yes, here we have superior thyroid artery, and here we have the inferior thyroid artery which is going posterior to the inferior lobe. Now you can see here in this diagram, we have a nerve here which is the vagus nerve. This vagus nerve is giving a branch here, which is this nerve, which is the superior laryngeal nerve, and here we have a branch which is arising from the vagus nerve, and the name of this nerve is recurrent laryngeal nerve. Okay, so here we are trying to tie the inferior thyroid artery. So nearer to the inferior thyroid artery in this diagram, you can see which nerve is there, recurrent laryngeal nerve. Okay, so we have basically related to the thyroid, we have two arteries, superior thyroid artery and inferior thyroid artery. The superior thyroid artery, it is related to a branch that is the external laryngeal nerve, so it cannot be the answer here. And the inferior thyroid artery, it is related to the recurrent laryngeal nerve, so this is the answer here, option D. So when we are tying the inferior thyroid artery during the operation on the thyroid gland, there may be a chances of injury to a nerve, and the name of that nerve is recurrent laryngeal nerve, which is a branch from vagus nerve. Okay, and the nerve which is related to the superior thyroid artery, that is our external laryngeal nerve. Okay, so we just have to remember these two nerves, external and the recurrent laryngeal nerve, which is related to the superior and inferior thyroid artery. Now we have question number 10, that is impaired function of which of the following muscle produce difficulty in protruding the jaw. Okay, now we just need to find out the muscle which is producing difficulty in forward movement of the jaw. So we have option, that is option A, anterior belly of digastric, option B, lateral pterygoid, option C, medial pterygoid, and option D, temporalis muscle. So these are the muscles, they are present around the jaw and then working on the temporomandibular joint for the movement of the jaw. So here we will see the answer. So here we have a muscle here. What is the name of this muscle? Inferior belly of digastric. And the action of the inferior belly of the digastric, that is depression of the mandible, which helps in the opening of the mouth. So the anterior belly of digastric is out from the option. Then we have other options here, that is the medial pterygoid, temporalis, and lateral pterygoid. So here you can see the action of medial pterygoid and temporalis muscle. So the medial pterygoid, it elevates the jaw, which means it helps in closing your mouth. Okay, the temporalis muscle, it has different fiber. The anterior fiber, it elevates the jaw, and the posterior fiber, it retracts the jaw, that is the backward movement. Okay, now we are left with a muscle which is lateral pterygoid, which is taking origin from this point, that is the infratemporal crest from the infratemporal fossa. And then we have one head which is taking origin from the lateral surface of lateral pterygoid plate, and then for the insertion, these fibers, they are going to the pterygoid fovea and the capsule of the temporomandibular joint. So when this muscle will contract, it will produce the forward movement at your jaw, that is called as the protrusion of the jaw. Okay, so our answer is the lateral pterygoid muscle. So the answer is option B. Okay, which is a lateral pterygoid muscle. So if there is the impaired function of the lateral pterygoid muscle, there will be a difficulty in protruding the jaw. So this is the answer here. Now we have another questions. Yeah, question number 11. The weakness of left deltoid and biceps brachii muscle could have resulted from the pressure on which nerve root? So the options are option A, the posterior nerve root of C5 and C6, option B, the anterior nerve root of C5 and C6, option C, the anterior nerve root of C7 and C8, option D, the anterior nerve root of C8 and T1, and option E, none of them. Okay, so we just have to find out the answer here. Now we have to see the brachial plexus here, because we all know the muscles of the upper limb, they are supplied by the branches arising from the brachial plexus. So we will talk about the nerve supply of deltoid, okay, and biceps brachii. Clear? So the deltoid muscle, it is supplied by the axillary nerve, okay, and the biceps muscle, it is supplied by the musculocutaneous nerve. Now the deltoid muscle, it is supplied by axillary, and axillary nerve, it is a branch which is coming from the posterior cord of brachial plexus, and it is carrying a fiber from C5 and C6. The root value of the axillary nerve is C5 and C6. Yes. Now the biceps muscle, it is supplied by the musculocutaneous nerve, which is coming from the lateral cord of brachial plexus, with root value again C5 and C6. Now we have this point here, the C5 and C6 is the root value for this axillary and the musculocutaneous nerve. Now we will just look into the options here. The option A, the posterior nerve root of C5 and C6. Posterior nerve root, we all know the brachial plexus, it is formed by the anterior nerve root of C5 to C8 and T1. So this is not the answer here. The anterior nerve root of C5 and C6, we have understood that the C5 and C6 is the root value for axillary and the musculocutaneous nerve, and the anterior nerve root will be there. Why? Because the brachial plexus, it is formed by the anterior root of the spinal nerve from C5 to C8 and T1. So this is our answer here, C5. The anterior nerve root of C5 and C6 will be involved there, and which will lead to the weakness of the deltoid and the biceps brachii. Now we will look into the another options. The anterior nerve root of C8 and T1, no, it cannot be there because the root value of axillary and the musculocutaneous nerve is C5 and C6. The anterior nerve root of C8 and T1, again it cannot be there because the root value is C5 and C6, and none of above it cannot be, because we have our answer, that is option B, anterior nerve root of C5 and C6. Okay, so this is our question number 11. So we just have to remember the root value of the branches arising from the brachial plexus. Clear? Now we have question number 12. So this is a question which is related to the lumbar puncture. So to perform a lumbar puncture in an adult, the needle is introduced between the spinous process of which vertebrae? So we have the answers: option A, L4 and L5, option B, L2 and L3, option C, S1 and L2, option D, T12 and L1. Now we will find out the answer. We all know what is lumbar puncture. The lumbar puncture, it is a procedure which is done to withdraw the CSF from the subarachnoid space. Yes. Now here in this diagram you can see the level of the spinal cord. The lower end of the spinal cord is called as the conus medullaris. Clear? Now this conus medullaris in vertebral canal, it ends between L1 and L2. So we just have to take a point for the insertion of the needle between below this level, below L1 and L2. Okay. So below L1 and L2, most commonly we take a point that is the L4 and L5, because this is the area which is more roomy here. Okay, and there is no chance of injury to the conus medullaris, which is the lowermost end of the spinal cord or terminal end of the spinal cord. So this is the safest side here where we perform the lumbar puncture. The answer is L4 and L5, between the spinous process of L4 and L5. So our options are option A, that is L4 and L5. This is the correct answer. L2 and L3, it cannot be done because there may be a chances for injury to the conus medullaris. Okay, and option C, S1 and L2, no, it cannot be. And T12 and L1, it is much higher level than the lower end of the spinal cord, so we cannot do at this point. Clear? So the answer is option A, L4 and L5. Yes. So that's it for today. We have discussed 12 MCQs of this series, and tomorrow at 7 p.m. we will discuss remaining 13 questions of the session of the series, that is the anatomy clinical questions. Okay, thank you so much.